Hi everyone, everyone here today. Today I'll be talking about thyroid disorders in pregnancy. There are a few gray area or insufficient evidence in some of the related to some of the thyroid conditions in pregnancy. So
hi, Dr. Htet. Sorry, we'll just get you to share your slides.
Oh yeah, sorry,
please.
It's not.
Thank you.
All right, is it sharing now? Yeah.
Yes.
All right. Okay. So before we talk about thyroid disorders in pregnancy, we'll just briefly talk about the physiology of thyroid gland in pregnancy. Now, as we all know, the fetus does not produce thyroid hormone until gestational week 19 or 20. Even then, that's not enough. So the fetus usually relies on maternal thyroid hormone. And as we all know, active T3 is the active thyroid hormone. However, T4 is the only thyroid hormone that can transfer across the placenta. So what usually happens is T4 will cross the placenta, then undergo deiodination in the fetus, and then locally converted to T3 for its action to be applied to the fetus. And moreover, in pregnant women, the thyroid hormone metabolism is increased. Now, this is due to mainly three things. As we all know, pregnancy is a hyperdynamic state. So in pregnancy, the renal blood flow is increased, as well as the glomerular filtration rate, which in turn increase the urinary excretion of iodine in the mother. And due to hyperestrogenic state in pregnancy, there is also increased production of thyroid hormone binding globulin up to 2-fold. So that itself also reduces the free thyroid T3, free T3 and T4 for proper action in the mother. And also in placenta as well, there is increased deiodinase activity, which then break down the thyroid hormone. So all in all, all these factors contribute to physiologic requirement of thyroid hormone being increased in the pregnant mother up to 50%. So if we look at a thyroid gland in a pregnant woman, there's increased vascularity as well as hyperplasia. And another effect or changes in thyroid gland or thyroid function is due to HCG hormone in the pregnancy. So HCG hormone, as well as TSH, FSH, and LH, they're all glycoprotein, and they're made up of alpha subunits and beta subunits. While beta subunits is quite unique to each hormone, alpha subunit is quite similar. So when someone is pregnant, depending on the level of HCG, the HCG can actually, the alpha portion of the HCG can actually go and stimulate the TSH receptor, just like how TSH would, and just like how Graves' antibody would. So we can say that HCG has thyrotropic action, but how strong it is. So if we have a look, the HCG 1 MIU per liter of HCG is actually equal to 0.013 MIU of TSH. So if we look at it at the number itself doesn't reflect it's a strong thyrotropic effect. However, the HCG level in pregnancy can be high, up to tens of thousands. So then adding that actually add up, and which then lead to increased thyroid hormone level in first trimester, and this in turn through negative feedback mechanism lower the TSH production from the pituitary. So if we understand this, we will realize that TSH level in pregnant women is physiologically lower than non-pregnant women, and depending on how much of HCG that a pregnant woman have, the TSH can be pretty low, especially in first trimester. So that's why we now have just trimester specific TSH ranges. Now this is this is the general, like this is the range that is commonly used, but obviously depending on the laboratory that we use, the TSH cutoff can be high or low. So it can be 2.5, in some laboratory can be up to 4. So it is very important not just to look at the number, but to actually look at the range. And when we order a blood test for pregnant women, always write the trimester and that they're pregnant, so that the laboratory will be able to interpret it correctly for you. Now, despite the fact that we have evidence to show that hypothyroidism or any type of thyroid disorder can have adverse effect on maternal and neonatal outcome, we actually don't have enough evidence to suggest or recommend universal screening of thyroid function tests in pregnancy, which is quite interesting. Now, we unfortunately don't have Australian guideline, but we do have, so we go according to the recommendation by American Thyroid Association guideline, which came out in 2017, as well as the guideline that was provided by Royal College of Australia and New Zealand obstetric and gynecologists. So this is a combined recommendation that I put on this slide, so you can use it as a reference. But all in all, we do, in clinical practice, I do suggest just looking at patients case by case and deciding whether we want to screen TFT or not, because the diagnosis of thyroid disorder in pregnancy is still underrepresented at the moment. So I'll just briefly go through the list. So very obvious symptoms of thyroid disease, although it can be quite difficult in pregnancy because fatigue is part of thyroid disorder, and all pregnant women are fatigued. And I mean, all of us are fatigued all the time. If there's a family history or personal history of thyroid disease or thyroid antibodies, if there's history of autoimmune disease. And in this recommendation, they said type 1 disease, but I do tend to screen for patients if they have celiac disease as well. If they're a bit older than 30, if they have morbid obesity, or if they're from area of known moderate to severe iodine insufficiency. So in Australia, most of our food are fortified with iodine. However, in some Asian countries, some European countries like Czech Republic, and some parts of America, they actually don't have enough fortified iodine in their food. So you have to screen these people if they come from that area. If they have previous pregnancy complication, in this particular recommendation, they said preterm delivery or miscarriage, but I do tend to, if they have any complication like preeclampsia, eclampsia before, I still do recommend checking it in clinical practice. Very rarely, if they have history of head or neck radiation, if they have infertility or subfertility, and if they have hyperemesis gravidarum. Now let's talk about subclinical hyperthyroidism in pregnancy. It's actually quite common compared with non-pregnant population. This is due to the previous factors that I've spoke about in the physiology of the thyroid gland. So mainly this is due to the HCG hormone, where HCG hormone actually increased significantly from fertilization up to the end of first trimester, and it peaks at 10 to 12 weeks. So what usually happens is about 2 to 5% of these patients, of pregnant women, or even more patients, this 2 to 5% is screened pregnancy. So because we're not screening everyone, there are a lot of people who might have been missed. And these women can sometimes, about 10 to 20% can have suppressed TSH level, not just low TSH, but like very suppressed, but they will have normal T4. And this is usually called gestational transient subclinical hyperthyroidism or thyrotoxicosis. And it's usually more common in twin pregnancy, pregnant women with hyperemesis gravidarum, and in Asian population. All we have to make sure is that they don't have antibody for Graves' disease, which is TSI antibody. And then we have to reassure the patient that this is physiological, but we will need monitoring. No specific treatment is required, and they usually settle at 14 to 15 weeks. Overt hyperthyroidism in pregnancy is even rarer. Again, the prevalence is about 0.1 to 0.4% in screened pregnant women, and about 85% is due to grave disease, and followed by the gestational transient thyrotoxicosis, followed by very rare cases like toxic adenoma or toxic multinodular goiter. Now, symptoms of overt hyperthyroidism can be confusing in pregnant state because of the pregnancy being hyperdynamic state as well. So basically persistent tachycardia, heart failure, things like that, and not gaining weight despite increased appetite. Those are the things that should trigger thyroid hormone testing. Investigations, imaging can be quite tricky. Normally with hyperthyroidism, to find out the cause, we will always do nuclear uptake scan. However, nuclear uptake scan is contraindicated in pregnancy as well as breastfeeding. So usually we will just rely on blood tests, but if we want, we can do ultrasound of the thyroid, but you have to ask for Doppler ultrasound to look at the blood flow itself. When we order, if we suspect hyperthyroidism, it is important to measure not only TSH, but T4, T3 as well, because the treatment would depend on how high the T4 and T3 is. The main thing is to check TSI antibody, and the best time to diagnose grave disease is in the first trimester, as is the highest. And in second and third trimester, due to pregnancy-associated immunosuppression, the antibody level goes low, and due to hyperdynamic circulation, it also gets diluted. So it's very important if you suspect hyperthyroidism to check it straight away rather than waiting for the TSH to improve. And the other importance of TSI antibody is that depending on the level of the antibodies, and like the TPO antibody, TSI antibody, the higher the level, the greater the risk of fetal and neonatal hyperthyroidism. And what else do we need to monitor if someone has if someone pregnant has hyperthyroidism and is on treatment, is to do frequent fetal ultrasound, so more frequent than what we would normally do in a normal pregnant woman. This is to look for signs of fetal hyperthyroidism. So the first sign is fetal goiter, followed by fetal tachycardia. Now, if they do have that, the treatment is, I'm not a pediatric endocrinologist, or an obstetrician, but basically the treatment itself, we don't need to treat the fetus itself because the anti-thyroid medication does cross the placenta. We just need to make sure the mom is treated adequately.
Can I just pause you, Dr. Htet? We've just had a question come through, and I apologize, I am not a clinician, so I'll need your help interpreting this. But the question is, what is TSI-AB? Is it TPO?
Okay. Sure. So sorry. So it used to be called TSH receptor antibody. Now it's called, you can still call it, but we now call it TSI antibody, which is basically thyroid stimulating immunoglobulin. Hope that answers. So basically it's the antibody for grave disease. We just changed the nomenclature to TSI rather than TSH receptor antibody. Does that answer the question? Yep. Think so. Okay. All right. Just gonna close the chat box. All right. So hyperthyroidism, and like the subclinical hyperthyroidism, the complication can be quite severe. In the mother, the main risk is preeclampsia and eclampsia, and the risk increased by 5 times. And together with hyperdynamic circulation, there is increased risk of congestive heart failure, which can be, the mortality rate is pretty high and there's risk of gestational diabetes, and there's increased risk of cesarean section as well if a mother has hyperthyroidism. With the fetus, it's mainly to do with the growth. There's intrauterine growth restriction, and if they're born, they have low birth weight, and people they can have preterm or premature delivery. Now, let's talk mainly about grave disease. Now, what do we do if we have we have a patient who has grave disease and they're about to get pregnant. Now, with all the thyroid disorder, it is always important to, if they are reproductive age women, it's always important to let them know that they need to inform their clinician if they're planning to get pregnant or as soon as they get pregnant. This is because we need to plan in advance as to what we're going to do even during preconception time. So there's a lot of young reproductive age women who has grave disease who are treated in remission, or who might be still on treatment and well controlled, or there might be people who actually not well controlled and are not taking medication regularly. And there's a few approaches to this in clinical practice. If I have someone who's young, who have who have time to wait before getting pregnant, and if they have uncontrolled grave disease, or if they have they require high dose of anti-thyroid medication to normalize the TSH, I will discuss about whether they want to have curative treatment before conception. Of course, there are patients who would prefer to do curative treatment even if they are stable, and of course that's patient choice as well. And the curative treatment we usually commonly use is radioactive iodine therapy, and very rarely we'll use surgery, only if there's contraindication over to radioactive iodine, or when they have cosmetic reason like a big goiter or a big nodule. And if we do decide to go for curative therapy, patients need to understand that they have to wait until they become euthyroid, so at least 6 months after radioactive iodine, and they have to be euthyroid on stable replacement therapy. We do so the patient has to agree to wait. This is very important. And the next approach is to switch to PTU before conception. Now, this is, as we all already know, we use PTU usually in the first trimester. Why do we want to change before conception? This is usually for young women who are very fertile, who can get pregnant in a few weeks. They have regular periods, no infertility issue. Then it's just safer to switch to PTU before conception because they will get pregnant straight away. However, we do wait for some. We do sometimes wait to switch only at conception if they're older women, if they have menstrual or ovulatory dysfunction. So they might take about 3 to 6 months to get pregnant. Then we tend to keep them on carbimazole because carbimazole is more potent. Sometimes patients do get very concerned about continuing carbimazole while they're trying to get pregnant. So you just have to look at them and look at their chance of fertility and pregnancy and have to decide and guide them. If we decide to wait until they get pregnant, it is important, and they're actively trying, you have to get them to do weekly pregnancy tests so that we know as soon as they're pregnant and we can change straight away to PTU. Now, when we look at grave disease and pregnancy, there are different groups of patients depending on the activity of their grave disease. So we have women who have stable active disease. So those are the ones who you cannot wean off the medication, but they're on carbimazole, might be like 10 milligram, but you can't wean them off the before pregnancy, so you continue. These patients, they usually can get more worsen, so the disease can actually worsen during early pregnancy. This is due to the addictive effect of the HCG stimulating the TSH. And some women who had remission before pregnancy can get relapse, especially again during the first trimester. And this is usually more common in women who have anti-thyroid medication therapy only like for a short course. So normally grave disease we recommend treating it for 12 to 18 months with medication, but sometimes patients get taken off medication because they responded really well, maybe within 6 months. These patients tend to have a relapse in the early pregnancy. Another thing is if they have grave eye disease, they tend to have more relapse. And obviously if they have TSI antibody. So in a woman, so in conclusion, even if they're in remission, if they have TSI antibody or if they have ophthalmopathy, you will be actively monitoring the thyroid function quite frequently in case they relapse, especially in the first trimester. Very rarely we might have a new diagnosis of grave disease in pregnancy, but it's usually either undiagnosed grave disease or they might have subclinical hyperthyroidism with TSI antibody, which then get worsened during the first trimester. And the same with the people who have undergone curative therapy. If they have persistent TSI antibody, they can relapse. So even though if they have curative therapy and had surgery, it is something that we still have to look out for and still need to check TSI antibody, even if they don't have a thyroid gland anymore. Treatment-wise, curative treatment like radioactive iodine is actually contraindicated in pregnancy as well as in breastfeeding mothers. And surgery we rarely use. So medical treatment is our only option. And both types of anti-thyroid medication can cross the placenta. So we like to use the lowest dose possible. Now we all know about PTU and carbimazole. In America, they use methimazole. So carbimazole just get metabolized into methimazole, which is the active ingredient. Now with the PTU has less risk of congenital malformation, and the congenital malformation that they get are quite minor compared with carbimazole, which has greater risk of congenital malformation. However, PTU does have increased risk of hepatic failure within 60 days of initiation. So it's very important to monitor the LFT in the first couple of months when we start the PTU. And the reason we use PTU in the first trimester, even though it's less potent anti-thyroid medication, is because between week 6 and week 10 is where the fetus is most susceptible to congenital malformation. So we will use the lowest dose possible. We'll change it to PTU. We monitor the thyroid function test every 4 weeks. If we change the dose, we check it again in 2 weeks. So it's a bit of blood test and patient can get frustrated. So it's very important to communicate with them clearly why we need to do this. And however, in the second and third trimester, as mentioned before, due to pregnancy-associated immunosuppression, doses can be lower or even wean off, especially if they're only on a small dose and they already have normalized TSH and the TSI antibody is either reducing or becoming negative. Then we can even withhold the anti-thyroid medication and see how the levels go. So it's sort of like it depends on case-to-case basis. The other thing to mention is even if someone has grave disease who is on medical therapy, at the time of conception, we can actually try conservative treatment. Now, this is obviously where you have to be quite you have to communicate really well with the patient to let them know that they cannot be lost to follow-up. So for this particular treatment, you want to choose someone who has had normal TSH, quite stable normal TSH on stable low-dose anti-thyroid medication, and they have had the anti-thyroid medication for a course of 12 to 18 months already, and also the antibody is also negative. All right, so what do we do with grave disease after delivery? Usually in postpartum, there is a higher risk of relapse of grave disease because the pregnancy-associated immunosuppression is no longer there, so there's autoimmunity is increased. So it is very important that they're carefully monitored, even if they're off treatment, because they can be a relapse. And it's usually occurs 4 to 8 months postpartum. And unfortunately, we can only use medical therapy. Although both carbimazole and PTU is secreted in milk, we can still give them, obviously, at a lower dose. At the same time, we do need to monitor the neonatal thyroid function test every 4 weeks. And you work together with the pediatrician for this. And carbimazole is actually preferred over PTU. All right, so I think that's it for the hypothyroid side of things. Let me have a look at the time. The time is all right. So we'll just move on to subclinical hypothyroidism. I'm going to spend a bit of time with subclinical hypothyroidism because, as I mentioned at the very start, this is an area where the evidence is quite conflicting and there's a lot of gray area. There's no like clear guideline. So I'll just go through some of the evidence and then explain why we do what we do. So subclinical hypothyroidism, as we all know, is raised TSH, normal T3 and T4. It's actually quite common, about 4 to 5% prevalence in the general population, and reproductive age women is even higher, 4 to 8%. And about 2 to 3% of screened pregnancy have subclinical hypothyroidism. And out of those, 50% tend to have thyroid antibody, either TPO antibody or thyroglobulin antibodies. Now, while there's evidence to show that subclinical hypothyroidism has been associated with maternal and neonatal adverse outcome, there's actually no strong evidence to show that treating the subclinical hypothyroidism before pregnancy actually prevent those adverse outcomes. So at the moment, whether the decision to decide whether we're going to treat SCH before pregnancy mainly depend on whether they have thyroid antibodies or whether they have fertility issues. Now, there's a lot of evidence out there. It's just that they're quite conflicting. I've just put up a few studies because there's a lot of studies. I'm not going to bore you with all the details, but if we look at these 3 studies that we're talking about, the first one is unfortunately, we don't have a lot of good study either. Usually they're all retrospective studies, or cross-sectional studies. So retrospective study of 394 women. And when they look at the infertile group and infertile group, it shows that infertile group have higher prevalence of SCH, about 13.9% compared with 3.9%. Another retrospective study, now this is looking at the whole group is women who has infertility due to several reasons. And it showed that subclinical hypothyroidism is prevalent is highest in women with ovulatory dysfunction, 6.3%, and then 4.8% with unknown cause of infertility, and 2.6% in women with tubal cause of infertility. So while the data looks like SCH prevalence is higher in this infertile group, especially with ovulatory dysfunction and idiopathic infertility, it doesn't necessarily translate that, SCH is the cause of ovulatory dysfunction or idiopathic infertility. Another prospective study of 358 women, again, they compare infertile group and infertile group. This study, which is prospective, so you would think that is a bit more reliable. This study, however, showed that there's not much difference in TSH level in both fertile group and infertile group. The prevalence of SCH is actually quite similar in both groups. So you can see that, it looks like there is a link, but we actually don't know whether is the cause, like I say, is a causal relationship. So let's talk about thyroid antibodies and infertility. Now, this is a meta-analysis back published in 2011, so about 11 years ago. And if you look at the studies that's included, you can see it's all the way back from 1999. So like 20 years ago, we actually don't have more we haven't done much more studies in this area. So you can see here, if you look at the forest plot, you can see that if somebody has subclinical hypothyroidism and thyroid antibody, either TP or TG antibody or both, their risk of infertility or subfertility is significantly higher than women without thyroid antibodies and subclinical hypothyroidism. Do let me know if I'm talking very rapidly, because I do tend to talk quite quickly sometimes. Now, this is a very interesting meta-analysis, and it only have 3 RCT in there. And all these RCTs are done in women who had subclinical hypothyroidism and undergoing assisted fertility treatment like IVF or ICSI. So intracytoplasmic sperm injection, that's what ICSI stands for. And you can see here very clearly that the odd ratio, when they are replaced with T4, the odds of getting favorable outcome is way higher. So when we talk about outcomes, is about fertilized eggs, so the number of fertilized eggs and the number of successful pregnancy and the number of live delivery as well. So and when they look at that, both the primary outcome and secondary outcomes, they are significantly better with T4 treatment. Now, unfortunately, these studies doesn't have everything in. So there are people who have SCH without antibodies, and there are people with SCH who also got thyroid antibody as well. So they're all grouped together. So based on that, what is the guideline for subclinical hypothyroidism? Now, we don't have any recommendation from Australia or the ANSC COG, but this is the guideline from, or the recommendation, I would say, not a guideline, but a recommendation from the ATA, American Thyroid Association. Just before I forget, I have put all the references in at the end of my presentation. So if you want to look at the guideline, it's all there. But I've only put in part of the guideline because it's about 25 pages, so I couldn't put all in. So what do we do with subclinical hypothyroidism preconception? So if we are undergoing assisted fertility treatment like IVF or ICSI, all subclinical hypothyroid women should be treated with T4 and try to aim for TSH less than 2.5. On the other hand, if they are antibody negative and they do have subclinical hypothyroidism and they have fertility issue, we actually don't have enough evidence to say one way or the other. But we do know for a fact that treating someone with a low dose thyroid hormone also doesn't cause harm either. So at the moment, the recommendation is you can consider giving thyroxine treatment to women with subclinical hypothyroidism if they have fertility issue, but they're not undergoing any fertility treatment. I hope that makes sense. It's a lot of words there, but that's basically, so basically it's up to us to decide whether we want to treat them or not. And in clinical practice, we do treat women if they have difficulty conceiving. We will put them on thyroxine treatment to increase their chance. Whether that actually improve or not, I think will depend on whether we can do RCT in the future, which which are, there's no actually upcoming RCT for this particular area. Now, what about pregnancy? If subclinical hypothyroidism is not treated during pregnancy, the preeclampsia rate is high, as well as perinatal mortality. Now, bear in mind that it's not as high as the grave disease, which is 5 times more, but still 1.7 times. And having antibodies also increases miscarriage and preterm birth. So it looks like the miscarriage risk is the highest with subclinical hypothyroidism. And this is highlighted in this study. This is a really good, like a decent study. It's prospective. It got 3,300 pregnant women. And they actually categorized the TSH level into SCH1, which is TSH between 2.55 and 5.22, and SCH2, which is between 5.22 and 10. And if we look at the miscarriage rate, you can see clearly that the higher the TSH level, the higher the risk of miscarriage. So the odd ratio for SCH1 is 1.62. And you can see here that this actually crosses the 1 mark, but the higher TSH level actually is very clearly favors the risk of miscarriage, and it's actually double the risk of SCH1. And antibody alone can also increase your miscarriage. And if we combine the presence of antibody and then stratify it according to the TSH level, the odd ratio is the highest if they have TSH more than 5 with antibodies. So the antibody, I mean here TPO or TT antibody, compare with SCH alone. So it's nearly 10 times if they have high TSH level with any type of thyroid antibody. So what is the current recommendation from ATA for treatment of SCH during pregnancy? So if you have thyroid TPO antibody and TSH above the pregnancy specific range, it is strongly recommended that you give them T4 therapy. And obviously, depending on how high the TSH is, you can start at 25 microgram daily or 50 microgram daily. It also depends on the patient's body size as well. So there's no one dose that fits everyone. So and the next recommendation is if you have positive antibody, TSH is above 2.5, but still in the pregnancy range, you can consider treating the pregnant woman, but it's sort of a weak recommendation. So which means we decide from depending on case to case. If somebody doesn't have a thyroid antibody, but TSH greater than 10, we will treat them regardless. As mentioned before, the higher the TSH, the greater the risk of miscarriage. And if they have negative antibody, but TSH higher than pregnancy specific range, you will treat them, but it's a weaker recommendation compared with TSH above 10. So you can see why sometimes it's a bit, it's all depend on the clinical scenario and the context. So it's good to know this recommendation, but it's all about discussing with the patients and working together with the patient. What about postpartum? So a lot of patients always wonder what will happen. Do they need to take the thyroid hormone after pregnancy? It's quite simple in a way that it mainly depends on the antibody and the level of thyroid hormone. Now, bear in mind that regardless of pregnancy in general population, only about 2 to 4% convert from subclinical to overt hypothyroidism annually. So it's very low risk. So, and if you look at this study in a prospective study of 82 women, a small number, but they did follow up for 9.2 years. You can see that TSH between 4 to 6, the conversion to overt hypothyroidism in that 9.2 year was 0%, which is quite convincing. Whereas if TSH above 6, about 50% of them will convert to overt hypothyroidism over that 9.2 years. So the current approach is, if someone has an antibody but TSH less than 4, you just stop the thyroxine after delivery and you just recheck in 6 weeks. If they have antibody but their basal TSH, so the very first TSH at the start of conception is more than 4, you continue the treatment and then check to see if you need to adjust the dose. If they have negative antibody but their TSH is above 4, then you can actually stop it and recheck it at 6 weeks to see if this is all due to increased demand from the pregnancy. Overt hypothyroidism, this is, I'm sure everyone knows how to treat hypothyroidism in pregnancy. Is very common. The new diagnosis of hypothyroidism in pregnancy is actually rare. It's usually the people that we see with hypothyroidism, they usually have the diagnosis even before. And in iodine deficient area like Australia, the most common cause of hypothyroidism in pregnancy is Hashimoto thyroiditis. So what happens if you don't treat it properly? Again, thyroid is linked to preeclampsia, eclampsia, and it also have fetal complication, in particular, the growth of the baby. But the different thing and the main thing here is, unlike other thyroid disorder, overt hypothyroidism, if not treated, can actually lead to low IQ in offspring, as well as language delay. There is also some, whereas subclinical hypothyroidism, there is no neurocognitive effect on the baby. Treatment is pretty straightforward. If someone has the disease, hypothyroid disease, as soon as they get pregnant, you just increase the dose by 20 to 30%. So just increase the weekly dose. However, some patients can require up to 50% increase in dose. And as mentioned before, T3, although it's active hormone, does not cross the placenta. So T4 is the recommended preparation. We do not recommend using thyroid extract or for treatment of hypothyroidism in pregnancy. And we monitor thyroid function tests more frequently in first trimester and every 6 to 8 weeks in second or third trimester. If they have pre-existing Hashimoto disease, as soon as they deliver, you can drop the dose back down to what they were before the pregnancy, and then just check it again in 6 to 8 weeks. So pretty simple. All right, how about women who have euthyroidism but have TPO or TG antibody? What do you do with them? Do you treat them during pregnancy or not? If somebody has antibody, it can transition to, I'm sorry about the typo. This is supposed to say is high risk of transitioning to subclinical hypothyroidism or overt hypothyroidism in first trimester if they have antibodies. So even if they are euthyroid, pregnant women who have antibodies should have TSH measurement every 4 weeks. And that's a very strong recommendation and high quality evidence. Now, what do we do with women who have thyroid antibody but have euthyroid and they are not undergoing assisted fertility treatment? These patients, would they benefit if we give them T4, in particular with the fertility? Would T4 treatment improve fertility if they have antibody but euthyroid? It's actually not recommended at this stage. However, I do know that in clinical practice, especially before we go on, we seek assisted fertility treatment, we sometimes put patients on thyroid hormone level, especially if they're in the upper range of the normal range. We might try a low dose of T4 to see if they achieve spontaneous pregnancy. Now, I'll just talk about postpartum thyroiditis because it's also quite common. It happens in about 7 to 10% of pregnant women, and it usually occurs within a year of delivery. So unlike the relapse of grave disease, which occurs within 4 to 8 months. And the interesting thing here is 60% to 85% have TPO antibody. Now, while it's commonly known that postpartum thyroiditis is a major cause of hyperthyroidism in postpartum, it can actually happen. There's actually 3 scenarios. So it can just be transient hyperthyroidism, or it can just be hypothyroidism, or it can be hyperthyroidism followed by transient hypothyroidism. And one of the predictive factors, a reliable predictive factor, whether someone will get postpartum thyroiditis or not, is if they have TPO antibody in the first trimester. So if they have TPO antibody in first trimester, their risk of getting postpartum thyroiditis is high. And unlike other thyroiditis, it's actually painless. And normally for the hyperthyroidism, we only use supported treatment such as beta blockers. However, for the hypothyroidism, if the patient is symptomatic or if the TSH is pretty high, we do replace them with thyroxine for about 6 to 12 months, and then we try to wean it off. The other significance of having postpartum thyroiditis is it increases the risk of having hypothyroidism later down the track. So we do recommend having annual TSH check for the next 5 to 10 years. Now, before I finish, I will just, there's a couple of questions that sometimes patients ask is about iodine replacement, whether, especially women who are more concerned about the baby, they will ask the clinician whether they need to take extra iodine. Is there any particular food that they need to avoid or eat more? I normally say no, because like I said, in iodine, in Australia, most of our food is fortified with iodine. So as long as the pregnant woman is taking pregnancy vitamin, that should be enough iodine for pregnancy. If you remember, there's increased renal clearance of iodine. So yes, pregnant women do require increased iodine compared with non-pregnant women. The WHO recommendation is about 150 to 250 microgram per day, and that's all included in the pregnancy vitamins. So most of the pregnancy vitamins have about 220 or 200 microgram. So that's something that you might get asked, so that you can tell the patients. There's also something about selenium as well. It's not recommended. And there's no need for extra iodine tablet or replacement just because they have thyroid disorder. Another thing that really we come across with pregnant women is thyroid nodules. So with thyroid nodule, unless they're quite big and they have suspicious features, we try not to poke them or operate on them during pregnancy, and we just try to delay it until postpartum. All right, so this is just a really nice flow chart that was published on the Australian prescriber website. Just put it there. I'm not going to go through it. It's a really nice flow chart. But obviously, always remember, as I mentioned before, always think about case to case and always discuss with patient what they would like to do as well. Again, all the references are in the in here. So, and you will get a copy of the PowerPoint in a PDF form after, I believe. I'm gonna stop sharing. Do we have any questions?
Thanks, Dr. Htet. We do have a few questions. I'll run through them. If someone with Graves' disease has had a thyroidectomy, can they still have thyroid complications during pregnancy?
Yeah, so that's the fourth group that I mentioned in Graves' disease. If they have TSI antibody, a relapse can happen. So if they have thyroidectomy and if they are planning to get pregnant, you just check the TSI antibody, and if antibody is negative, you just monitor the thyroid function test as a regular, like the usual, guideline. But if they have TSI antibody, you have to let them know that they can be relapse, and especially in the first trimester.
Thanks for that answer. The next one was, what are the differences between thyroid ABS and thyroglobulins ABS and TSI?
Okay. All right. So thyroid, when I mentioned thyroid antibodies, we usually refer to, if you order the blood test as well, when you order thyroid antibody, it only includes TPO and TG antibody. And then the TSI, so that's for the hypothyroid, and TSI again is thyroid stimulating immunoglobulin antibody, which is for Graves' disease, for hyperthyroidism. Can you briefly explain what various? Okay, so I've mentioned some of, I probably answered part of that question already, but basically, why do people have this? We don't know, because we do if we actually screen or test everyone in the world, the prevalence of having antibodies would be pretty high. All right, that's why we suggest we suggest, no universal screening. But having antibody, does this necessarily mean that they will have thyroid disorder 100%? No, there's actually no way of predicting if somebody has thyroid antibody, they're going to have thyroid. For example, if they have TPO antibody, they will have Hashimoto 10 years down the track. So it actually doesn't work that way. All we can explain to patient is you have antibodies, so that means that you are at high. For example, if you have a Graves' TSI antibody, you can say that at one point you might develop Graves' disease. So it's important that if you're unwell, if you have these symptoms, we need to check the thyroid function. And also we have to tell them that this antibodies means that if you're going to get pregnant, this might happen. For example, if you have TPO, if someone has, so I get sent a lot of patients with TPO antibody who come to see me, worry about what that means. I usually tell patients, look, I don't need to put you on any treatment. It doesn't necessarily mean you will have hypothyroid now or 10 years down the track or 5 years down the track. What it means is if you are in reproductive age, we just have to bear in mind that you might have some fertility issues. So if you are planning to get pregnant, come have a chat with me so that we can discuss it together. The same with subclinical hypothyroidism and antibody as well. Does that answer Matthew's question of the first one?
I think so. And then that last one, should we be doing a radioactive thyroid scan to diagnose postpartum thyroiditis?
So it depends on whether the patient is breastfeeding or not. If they're not breastfeeding, you can do a nuclear thyroid scan, and which will basically show reduced uptake, just like any thyroiditis. But basically, if someone has hyperthyroidism in postpartum period, is either Graves or postpartum thyroiditis. So all we need to do is check the thyroid hormone and TSI, and that would usually give us a decent like enough clues to decide what we want to do. And the other thing, this is a bit more, so with postpartum thyroiditis, or with Graves' disease, T3 tends to be much higher, but it's not always true, so I tend not to say that. but usually postpartum thyroiditis symptoms are a bit less severe compared with grave disease. Hope that answers questions.
Thanks,